Welcome back. Now we are reaching the last segment of this International Diabetes Update 2020. And now the focus will be shifting towards revisiting the role of statins in treating our people living with diabetes. To moderate this session, it's my pleasure to invite Dr. KamaniLiyanarachchi, consultant endocrinologist from Sri Lanka, and she'll be joined by Dr. Sanjay Kalra, consultant endocrinologist and diabetologist from India. Over to you, madam. Over to you, sir.
Thank you, Harsha. Welcome you all to this final session of the day, which is a very important topic. This is update 2 on comprehensive diabetes care. Revisit statins in diabetes. We have 4 eminent speakers who are joining with us today. And the first speaker is Professor Nuria Alonso from Spain. She is physician, endocrinology and nutrition specialist, German Trias University Hospital, Spain. We also have Dr. Unnikrishnan, who is an endocrinologist and CEO of Kalra&Dr. Diabetic Institute, Pune. Also, Dr. Khalid Shaikh, a senior diabetologist and specialist physician in internal medicine, Royal Oman Hospital. And also Dr. ZhanayAkanov, he's the head of clinic in internal disease as Fendio Kozak National Medical University at Kazakhstan. So let's move on to the first topic, which is current guidelines in perspective, evidence, and targets in dialogue. Over to you, Professor Nuria Alonso.
Thank you very much for your introduction. Good afternoon. First of all, I would like to thank the organizing committee the invitation to participate in the meeting. It's a great pleasure for me. As you may know, atherosclerotic cardiovascular disease and diabetes show epidemic proportions worldwide, also in India. Cardiovascular disease in South Asia is characterized by its high prevalence and prematurity, and also by an atherogenic lipid profile consisting of hypertriglyceridemia, low HDL levels, and an increased concentration of small LDL particles, together with increased levels of Lp(a) compared with other ethnic groups. It's now widely accepted that LDL plays a causative role in atherosclerosis. Results from multiple studies have shown that there is a direct linear relationship between LDL concentrations and cardiovascular disease risk. We also know that non-LDL cholesterol, which includes all atherogenic lipoproteins, is a more accurate predictor of cardiovascular risk, especially in those subjects with hypertriglyceridemia, such as those with diabetes or metabolic syndrome, and also in statin-treated patients. Statin treatment in patients with diabetes is associated with a 21 risk relative reduction of measured cardiovascular events per each 40 milligrams deciliter reduction in LDL cholesterol, regardless of the initial LDL cholesterol level. This proportion is the same as that observed in non-diabetic subjects. We should point out that patients with the highest global risk of cardiovascular disease benefit more from greater reductions in LDL, and that the longer it is maintained, the greater the benefit. Further, we should also bear in mind that as the same percentage reduction in LDL cholesterol, the higher the basal cholesterol, the greater the reduction is in absolute cardiovascular risk. As for the guidelines, I will first discuss the American guideline published in 2018. This guideline, LACODAS, emphasize the need of adherence to a healthy lifestyle through life course. Regarding primary cardiovascular prevention, the guideline recommends to start a moderate intensity statin in patients with diabetes aged between 40 and 70, regardless of their 10-year calculated cardiovascular risk. The guideline also points out a subgroup of patients with diabetes in whom it's reasonable to initiate high-intensity therapy. These are those aged between 50 and 70 years, those who have risk diabetics, risk enhancers, or multiple risk factors. In this guideline, sodium-anxious 3 is considered among the risk-enhancing factors. There is no risk, there is no specific validated cardiovascular risk equations for patients from native South Asian people. This guideline recommends to use the UK risk equation, with the caveat that we have to bear in mind that this has been validated in South Asian people, but only from UK. Patients with a clinical atherosclerotic cardiovascular disease are considered to have high risk. In this patient, the guideline recommends to initiate high-intensity treatment with the aim of reducing equal or more than 50% of LDL cholesterol. Those that are considered at very high risk are those who have a history of multiple previous cardiovascular events, or one cardiovascular event plus another high-risk conditions, among which there is diabetes mellitus. In this group of patients, the guideline considers the addition of ezetimibe and later on PCSK9 inhibitors in those patients who don't reach an LDL cholesterol below 70. PCSK9 inhibitor is considered, as I said, in this group of patients. The 2019 guideline, European guideline, classifies diabetic patients with target organ damage or at least 3 major risk factors or early onset of type 1 diabetes of long duration in the very high risk group. Those without target organ damage or with the diabetes duration longer than 10 years or another risk factor are considered a high risk group, whereas those young patients with DM1 duration less than 10 years without other risk factors belong to the moderate risk group. Both the American guideline and the European guideline consider the use of cardiac imaging techniques in the subgroup of intermediate risk to better redefine their cardiovascular risk, leading to reclassification in some of them. The European guideline states LDL cholesterol goals. In case of the very high risk, this goal is lower than 55, and in the high risk is lower than 70. But this value must also be accompanied by a higher or equal than 50 reduction of LDL cholesterol from baseline. So as I said, the guideline states that you have to reach an LDL cholesterol level according to your risk category. So you have to initiate or implement the highest statin dose to reach this goal. In case you don't reach this goal, the guideline recommends to add ezetimibe, and in those cases, especially in those in secondary prevention or family hypercholesterolemic patients, to add PCSK9 inhibitors to reach this goal. But we have to know that the maximum lowering effect of a high-intensity therapy on monotherapy is 50% reduction. If you add ezetimibe, this reduction increases to 60. And if you give a combination of a high-intensity therapy with ezetimibe and PCSK9 inhibitor, the reduction achieved is 84%. A group of Spanish lipidologists led by Dr. Massana, as I put here in the slide, has recently published a table for planning the lipid-lowering therapy, taking into account the initial LDL cholesterol level and the cholesterol level you have to achieve, the goal of L cholesterol level. Finally, I'll comment a little bit about the expert consensus statement on management of dyslipidemia by a group of expert lipidologists from India, which was published in 2016. In this consensus, patients with diabetes with evidence of end organ damage or with more than 2 other major cardiovascular risk factors are considered a very high risk group, whereas patients with diabetes with no or 1 other major cardiovascular risk factors and no evidence of organ damage are in the high risk group. For each risk group, the consensus states LDL values to reach. For the very high risk is an LDL below 50, and for the high risk below 70. The current situation is that in the real world practice, the use of statins and the achievement of LDL cholesterol levels in patients who are in the very high risk or the high risk group is far from what is recommended in international guidelines, both in Europe and also in India. In Europe, less than 30 reaches an LDL cholesterol level lower than 70. And in India, the use of statins in this group of patients is nearly 80. Also, it has been demonstrated that early statin withdrawal is associated with increased risk of myocardial infarction and death from nearly finishing and cardiovascular death. Finally, all guidelines agree on the importance of implementing healthy heart style life across all life course, that is diet and physical exercise. And I'd like to mention that Indian diet, as you all know better than me, has a high percentage of refined carbohydrates and saturated fats, and that in order to reduce cardiovascular risk and to control lipid parameters, it is considered to reduce the intake of saturated fats and refined carbohydrates, and to increase proteins from plants and from fish, poultry, and dairy. The example of this is the Mediterranean diet, in which in the Predimed study showed its association with a reduced cardiovascular risk. Finally, my conclusions are that healthy lifestyle is the cornerstone of atherosclerotic vascular disease prevention, that effective management of dyslipidemia is critical to reducing overall cardiovascular risk in subjects with diabetes, that atherogenic cholesterol, which includes LDL and non-LDL, is the primary target of lipid-lowering therapy in patients with diabetes. Statin treatment is the first-line agent for lipid lowering in patients with diabetes. The majority of patients with diabetes are candidates for statin treatment, high, most of them are moderate, that non-invasive cardiovascular imaging techniques can help with the reclassification of risk, mainly in the moderate group, and that cardiovascular risk equations validated in Indian population are needed to improve the lifetime and ideally the lifetime and also the short-term cardiovascular risk in this population. And finally, that the discussion with the patient is the cornerstone of shared decision-making. Thank you very much for your attention.
Thank you, Dr. Nuria. Yeah, thank you very much. That was a wonderful talk, and you've been able to summarize guidelines from across the world for us. What we understand is that we have to treat lipids. The threshold may vary from person to person, but the cornerstone finally remains statins, along with lifestyle modification. The comment on South Asian diet and Mediterranean diet is well taken. We hope to invite you as soon as COVID is over to actually sample South Asian diet, the tastiest diet in the world, in India or Sri Lanka next time. Dr. Khalid Shaikh is from Oman. Along with him, we are working on an Arabian Sea diet, a healthy alternative to the Mediterranean diet. So I'm sure he'll be happy to invite you to Oman and the Middle East as well. We'll continue with this discussion. Thank you. And we'll have questions at the end. It's my pleasure to invite Dr. Unnikrishnan, who has already been introduced. So Dr. Unnikrishnan, Dr. Nuria has put the guidelines in perspective for us. We know that we have to use statins. Can you share some clinical pearls from your practice, from your experience and evidence both, and of course the eminence that you enjoy in South Asia? So how do we use statins in a patient-friendly manner?
Thank you, Dr. Sanjay. I'm trying to share my screen, but it's coming as the host has disabled screen sharing. So requesting the team to allow me to share the screen.
That's like you advising statins and your patient not accepting. So then what do you do?
Yes. But now finally the patient has accepted, and the screen sharing also has been accepted. So once again, Dr. Sanjay, thank you for the kind introduction. It's a pleasure to be here along with Professor Alonso, Dr. Shaikh, Dr. ZhanayAkanov, all of you. So I'm going to talk about some clinical pearls, and let me begin with a case. So this is a 58-year-old gentleman who works in a high-stress job. His BMI is 28. Note that his HbA1c is 6.4%. He's on metformin, rosuvastatin, telmisartan, and aspirin. Well, I'm going to talk about 2 or 3 clinical areas here, because if you see that gentleman's treatment is as per guidelines, I'm going to talk a little bit about statins and myalgia, statins and diabetes, and a simple summary. So let's look at another gentleman, 34-year-old male smoker, recently diagnosed type 2 diabetes. But look at his HbA1c. It's 6.4% now. So he's on diet, his HbA1c is 6.4%. His total cholesterol is 245. His LDL is 128. His HDL is 48. His triglyceride is 144. And VLDL is 28. So earlier I showed you an older gentleman, and now I'm showing you a younger person. In both cases, the HbA1c is 6.4%. One, he is on metformin, the older gentleman. This young gentleman is not on metformin because he needs to stop smoking, and we won't discuss aspirin and diabetes treatment, etc. But we'll focus on just statins. So we know that statins can cause diabetes. So studies have shown that if you treat 255 patients for 4 years with statin, you can get 1 case of diabetes. At the same time, if you treat 255 patients for 4 years, you get 5 less cardiovascular disease. So you will agree with me that the odds are very much in favor of treating with statins, even if it increases 1 case of diabetes. But remember, this young gentleman's HbA1c is 6.4%. And the older gentleman was on metformin, but the young gentleman is not on metformin. So if you treat this patient with statins, and if his HbA1c is 6.4, you just push him to 6.5, 6.6, he becomes diabetes. And if you have 200 diabetes patients for 4 years, approximately you will get 16 cases of retinopathy. 200 diabetes patients for 4 years, you get 50 cases of microalbuminuria. If you treat 200 diabetes patients and they have diabetes for 4 years, you get approximately 40 cases of neuropathy. So it's not that easy. That's what I'm saying. Yes, statins cause 5 less cardiovascular disease, may cause 1 case of diabetes, but even that 1 case of diabetes, remember, diabetes is a cardiovascular disease, but it's not just a cardiovascular disease. Diabetes, of course, is a cardiovascular disease, and you need to treat with statins to protect the heart. But remember, the patient with diabetes, as shown in the picture in the middle, you cannot afford to have an amputation, for example. So neuropathy is something you'd like to prevent. Retinopathy is something that you'd like to prevent. And therefore, I think the decision is a little more complicated. And this is what the ADA 2020 guidelines say. If a patient with diabetes is less than 40 years and has no risk factors, there is no indication for statin therapy. Now, if the age is more than 40 years, and even if there is no risk factor, you need to give statins. So I'm focusing on diabetes here, but the key message is every patient with type 2 diabetes above the age of 40 years needs to be on a statin. You have to decide whether it's a moderate intensity statin or a high intensity statin. That's the only decision to be made. But if the age is below 40 and if there are no risk factors, I think we should be cautious about statin therapy. But if the age is below 40 and if there are risk factors, again, the patient needs statin therapy. Now, this is a very famous study called the GAUS-3 randomized clinical trial. This looked at evolocumab versus ezetimibe. But I'm going to look at just the atorvastatin versus placebo in this study. So if you look at it, if you look at all the randomized patients, out of the 491, 209 people had myalgia or muscle-related symptoms with atorvastatin, but not with placebo. Now, 26.5% had symptoms with placebo, not with atorvastatin. 10% or 9.8% had symptoms with both placebo and atorvastatin. So I put the calculation at the bottom. If you assume that 43% had myalgia with atorvastatin, and if you subtract the 26% who may have had symptoms with placebo also, and another 10% who may have symptoms with both placebo and atorvastatin, 43 minus 36 works out to 7, which means that approximately 7 out of 100 people that you treat with statin may have some degree of statin intolerance, which works out to about 15%. So 1 in about 15 people on statin may have statin intolerance, may have true statin intolerance. So we are not talking about, symptoms with placebo. This is true statin intolerance. So studies have shown that 1 in 15 may have statin intolerance. So therefore, we need to consider this as well. So this is a very simple summary because I've been given 7 minutes and I intend to try to finish on time. So wherever there is a high risk patient, young or old, you have to treat with a statin, and you have to treat with a moderate or high intensity statin. Now see the picture in the middle. That picture is patients who have had a myocardial infarction. Again, no question, you'll have to treat with high intensity statin. The only question is in the low risk patients, where you're looking at a primary prevention scenario. There, that's the only group where statins in diabetes may not be appropriate in all patients. So friends, statins have one of the best possible evidence for any molecule, more than 30 RCTs, all RCTs positive. They cut down the risk of cardiovascular disease by 30%. They're cost effective, safe, lots of benefits. But they are useful only for the right patient at the right time. They are not for everyone, not for young people of 20, 25 years, even if they have diabetes and no risk factors. But clinical judgment is critical, and any type 2 diabetes more than 40 years needs to be on a moderate or high intensity statin. Any type 2 diabetes below 40 years with risk factors such as smoking, family history of CAD, again, you need to put on statins. I've tried to discuss some of the clinical pearls, and I've also shown you the numbers relating to diabetes, relating to diabetes, retinopathy, neuropathy, nephropathy. And remember, statins, there have been some Indian studies which show that statins may reduce LDL and protect against retinopathy. And I also showed you that 1 in 15 people may have true statin intolerance, whereas all the others may not have. So statin intolerance is not that common. So ladies and gentlemen, it has been a real pleasure discussing this topic with you. And thank you so much for listening to me.
So thank you so much, Dr. Unnikrishnan. Let's move on to the next topic because of the interest of time. A glimpse of newer therapy in South Asia by Dr. Khalid Shaikh from Oman.
Good day and thank you very much. I will continue with what Professor Nuria and Dr. Unnikrishnan had continued. We will go into the management of dyslipidemia within a South Asian perspective. And here, what we will try and discuss is dyslipidemia, a unique challenge specifically for a South Asian population. Then recommendations after lifestyle and statin, then the newer therapies in management of dyslipidemia. Now, dyslipidemia in South Asia, it has a fatal and unique attraction. Obesity, of course, is there, but it's more of a central obesity or abdominal obesity, which is intra-abdominal and truncal. Along with that, they have ectopic sites like liver and skeletal muscles. All of these causes increased insulin resistance and concomitant metabolic syndrome, which includes the fatal atherogenic dyslipidemia, which we are discussing in today's profile. Now, this is what Professor Nuria had already explained to us, which the 2019 European Society of Cardiology has given us in an algorithm form, wherein we start with the risk assessment, then we go in for diet and lifestyle, then you go into high potency maximum tolerated statin. Once that has been achieved and still the patient is not on target, the next step is to add ezetimibe. And that is as per the European Society of Cardiology. Here, I would like to add in one more point is, as per the ACE 2020 guideline, they have asked for addition of PCSK9 in this stage. And that's in a very, they have categorized it as extremely high risk patients and very high risk patients. So here we can add in PCSK9 inhibitor as primary as well as secondary prevention, especially with familial hypercholesteremia. Now, what are the newer therapies in the management of dyslipidemia? So first, as we all know, is our good old ezetimibe. Now, ezetimibe actually is not a newer therapy, but it is a very effective therapy and it prevents cholesterol absorption. And this is done basically with the action of inhibiting NPC1L1 cholesterol complex. This prevents the absorption of cholesterol from the small intestine and thus decrease delivery of cholesterol to the liver and decrease hepatic cholesterol stores. So this is the ezetimibe, which comes immediately next step to the statins. After ezetimibe, we have the newer generation, which are the PCSK9 inhibitors. Now, basically, they are human or the monoclonal antibody. Now, the PCSK9 basically is an enzyme in liver that binds and blocks the receptors of LDL. Thus, the LDL removal from the blood is not happening and it causes increased blood level of LDL. Now, PCSK9 inhibitors, what they do is they inactivate this particular enzyme, so causing more receptors available to absorb the LDL. And thus, it causes decrease in LDL-C cholesterol, which almost can go up to almost 56 to 60%, as we had seen in our previous slides, that it can go up to almost 80%. Now, the two molecules which I would like to refer as far as PCSK9 inhibitors are concerned are the evolocumab and the alirocumab. Now, the half-life of evolocumab is almost 11 to 17 days, which is quite long. And then alirocumab is also around 17 to 20 days. And they are given as subcutaneous injection at the dose of 140 milligram every week or 420 milligram once every 4 weeks for evolocumab, and alirocumab is 75 milligram subcut once every 2 weeks, or you can go up to 300 milligram once every 4 weeks, especially in cases of familial hypercholesteremia. Now, besides lowering the LDL cholesterol, the beauty about PCSK9 is it has an anti-inflammatory effect, which is seen more on the coronary endothelial dysfunction. And this has been showed in studies like the EVAX and the EVOLVE. The EVAX study basically was an evolocumab in acute coronary syndrome. And this demonstrated the potency and rapid action of evolocumab in peri and early post-ACS period. So we are talking about these patients who have had an acute coronary syndrome. And the PCSK9 were used in these patients. It is basically a very high risk pro-inflammatory time, especially post-ACS. And when this is the time where an elevated atherogenic lipid profile is associated with increased risk of adverse ischemic outcomes. The other study which I would like to highlight is the EVOLVE study, which was effect of evolocumab on coronary endothelial function. And this study is, by the way, the first clinical study providing proof of concept that evolocumab rapidly improves coronary endothelial function in individuals with pro-inflammatory state. Now, pro-inflammatory states, but without coronary artery disease. And the examples we can say are the HIV or dyslipidemia. So in a nutshell, PCSK9 not only work at the level of LDL cholesterol, they also work at the level of anti-inflammatory, especially for the coronary endothelial dysfunction. Now, these are few studies which I'll quickly go through, like the Improve It, the 4-year and the Odyssey outcomes. In the Improve It, they have compared simvastatin monotherapy and then simvastatin ezetimibe. In the 4-year, they have compared a placebo with evolocumab, and the Odyssey, they have compared placebo with alirocumab. And all these three studies have shown beneficial effects as far as the 4-point MACE is concerned. That's the major adverse cardiovascular events. And they have shown that PCSK9 is beneficial in all 3 levels. The newer kid on the block is the small interfering RNA. Now, basically, they are nucleotides. Now, nucleotides are the building blocks of DNA and RNA. And we have 2 major classes of agents here. One is antisense oligonucleotides, which are ASO, and the small interfering RNA, which are the cRNAs. And what it does basically in a plain simple language is it uses body's RNA interference process to selectively block the PCSK9 in the liver. So both are working on the same, like what we discussed, the PCSK9 inhibitors and the PCSK9 blockers. Both work almost on similar line, and at the end of the day, what we get is the increased liver's ability to eliminate the LDL cholesterol from the bloodstream and thus lower the cholesterol levels. The dose is 300 milligrams subcut initially, next at 3 months, and then you have every 6 months. So basically, this particular molecule can be given just twice a year to get a good control. And as I said, this cRNA or the ASO, they not only work at the PCSK9 level, they also work at the ApoC3, at the ApoA, and they also work at the angiopoietin-like 3 level. So thus giving a reduction in all the levels of lipid profile. These are on the left side, if you see that statins you are giving every day, then you have the ezetimibe, which is given every day. Then we have the PCSK9 inhibitors, which are given once in a month or twice in a month. And then you have the latest molecule, which are the PCSK9 cRNA, which is given only twice a year. And the effect are equal, but the later molecule like PCSK9 and now inhibitors and siRNA have much more reduction in the LDL cholesterol, as well as giving the additional benefit of cardiovascular safety. So to conclude, the future of lipid lowering strategy to reduce cardiovascular LDL cholesterol should be, the concept 1 should be start early. Less LDL cholesterol exposure leads to prevention of lesion formation. Concept 2 is treat aggressively, treat to the desirable target, use therapies. And the concept 3 is use combination therapy at the earliest stage. It could be a statin, it could be ezetimibe, it could be a PCSK9 mono antibody. Now, also in this, I would also mention the cRNA oligonucleotides like inclisiran, which is the next generation lipid lowering drug. With that, I would like to thank you for this. Thank you very much.
Thank you, Dr. Khalid. That was a masterly overview of the future that we have. Of course, much of this is present. In South Asia, we use ezetimibe and we also use the PCSK9 inhibitors, but you have added more to our information, our knowledge. So Dr. Nuria began by speaking about guidelines. Dr. A.G. Unnikrishnan took us into the OPD, into today's clinic, and Dr. Khalid added to that. And we now have a very strong call for action. But along with action, we should also have caution. So we have with us Professor ZhanayAkanov, who is president of the Kazakh Society for Study of Diabetes. Dr. Zhanay, would you like to speak about adverse effects that you see in your practice? Do you see adverse effects with statins? And if so, how do you handle them? I will be sharing the screen for you. So Dr. Zanay, warm welcome to South Asia. And we look forward to hearing from you.
So dear colleagues, thank you very much, Professor Alonso. I'm very happy to hear you and colleagues also. Dear the chairman, dear Professor Sanjay Kalra, at least I want to say my words of appreciation for you, for your support. We're working together more than 5 years. And so, you know, I'm very impressive of the level of your research and your team also. And very happy today to be here with our friends from Federation. Yeah, of course, South Asia Federation is very important thing. Okay, it's about the statin-related adverse effects. Yeah. Okay, so I tried to use, but so I think that it's not possible. Next, please, Professor Kara. Yeah. So, of course, the why statins, yes, it's no any questions. We're understanding why we should use the statins. Should talk about before it. That's yes, of course. A lot of them, same. We can say there's some conflicts between the researchers statins without any colleagues who want to try something new. A conflict of interest between the groups of the researchers about 20 years, yeah, and we know that some statins, of course, show some results that's not so good, but in the general aim, we can say that adverse effects of introduction statins, of course, they have. Yeah, we know the situation with the side effects. Statins, they have the deeper absorption, bioavailability, plasma protein binding, expression, yeah, of course, lipophilicity. We know, but why are we speaking about these statins without without any problem? That's we should to use. That's they're also the effect, general effects. Yeah, it's very important for us because how to say that if we can comparison the problem with cardiovascular system and atherosclerosis and also diabetes and to look to the side effect, of course, we are understanding that we should use statins. Next, please, if possible. Yeah, the muscle symptoms is very important. It's mostly a problem for the person who using statins. Yeah, of course, we show the problem with the patients who using the statins. Of course, the SANS, the most prevalent and more important adverse event. I think that is more than 70% from all of the events of the muscle related. Of course, the myalgia, myopathy, myositis, and some problem with elevation of the creatinine kinase. Of course, but in my practice, I cannot see the rhabdomyolysis at least just every day or every week or every month. Yeah, we have a problem, and we can see that CK is increasing. Yeah, but we can to use general instruction. I think that general clinical protocols from international organizations. I think that's any international organization, same like ADA, ASD, ESD, American College of the Cardiologists. Yeah, and I think that we can make them some individual approach for some syndrome in the patients with diabetes. And I don't think that is a very big problem. Of course, the myalgia and myopathy, we can see, yeah. It's true, but next slide, please. But mostly our colleagues from the research group, our colleagues from research group, they can show to us that we cannot say that rhabdomyolysis is a the usual side effect, usual adverse effect for this patient. And actually, yeah, the general scheme, you can show the left side of this slide. You can say, you can say that is, that is very I think you know everything from this skin, and I don't think that is something new for everybody, and for especially for today is very respectful group. Next slide, please. Okay. So in the next slide, we can say about the another adverse effect, same like the adverse effect on the liver. Yeah, today I have spent, I think that's a very good time about listening about non-alcohol liver disease, yeah, NASH. And of course, for our endocrinology service is very important, especially the patients with diabetes and obesity. And of course, we should think about some adverse effects. Fortunately, we have no any very dangerous data about the adverse effect on the liver. It's very important thing. Why? Because now we should change that. We should try to change our policy. One of these, we should think about NASH in all patients with diabetes type 2 and with a problem with liver dysfunction. It's very important. Fortunately, we have the current evidence suggests that statin therapy to be safe in the patients with NASH and may confirm more efficient treatment for viral hepatitis and some cirrhosis. So we cannot say that there's a big problem. Of course, the new onset diabetes, NOD, yeah, it's a very important thing because NOD is a big problem. But we should understanding another, again, we should think about dysglycemia is more important. Of course, is a dose-related effect. So I think that's more than 50 studies shown that this is a problem. Can you hear me? It's good?
Yes.
I think there's some problem. Yes. Can you hear me?
Carry on. Yes, we can.
So I think that's about diabetes, and of course the risk of new onset diabetes. Yeah, of course, is absolutely correct. There's increased risk, but we should think that also the number needed, of course, of the case of diabetes has been estimated, or only 255 over 4 years of statin treatments. Please do not forget that in this situation, we should use the same situation like HbA1c. That's for reduce HbA1c, we should work very hard. So this situation also is very important for our patients. Next is increasing the risk of the hemorrhagic stroke. Of course, this is some researchers show to us if we're using the effective regime about 40 mg atorvastatin daily. Yeah, from 10,000 patients for 5 years, yeah, we will have 5 to 10 cases of hemorrhagic stroke. Please do not forget these is the numbers. Yeah, why? Because when you have a strong mention about the hemorrhagic stroke, at least you should think about what kind of statistic about another vascular complication of diabetes you will have with this patient. Of course, kidney function. This is also very good. There is no clear evidence that statin have a clinical significant beneficial of the adverse effect of the renal function. It's very important. Today, I have happy to hear the very good data about diabetic nephropathy in the patients with diabetes, and it's very important, especially when we're using in the patients in the group, elderly group, and they have stage of the diabetes more than 30 years. So, okay, I almost finished that. And last is the statins and testosterone levels in the men. It's very provocation TM. Why? Because we should understanding that erectile dysfunction on the patients with diabetes is already present, and that we should think maybe when the reduction of the total and free testosterone is linked with the development of erectile dysfunction of this patient. And last one is the conclusion. In the conclusion, I want to say that I agree with our colleagues today, and I think that we should use and try to do not make mistake on the patients with diabetes when we're trying to find good position, good version for the patients with dyslipidemia. Thank you very much, dear colleagues. Sorry for my link. Maybe that is too much slides, but I tried to explain my approach for the patients with dyslipidemia with diabetes mellitus. Thank you very much.
Thank you very much, Dr. Akanov. So let us now move into a few questions. Because of the limited time, we can go into few questions only. So I would like to ask the first question from Professor Nuria, and Dr. Unnikrishnan can also contribute. So we have evidence to tell that people who have diabetes and more than 40 years, it's better to start statin. So that Dr. Unnikrishnan, you showed that. But what about people who are less than 40 years? And then what about, so in them, the cardiovascular risk scores are quite useful to decide whether to start statins or not. So can you please elaborate on that? What kind of, for South Asians and for people who are less than 40 years, what risk score is the best to use? And just what are the indications to use statin in that group of people, young people?
Do I answer first?
Yes, please.
Yes, please.
Yes, please. Yes.
I would say that first of all, and this in people aged below 40, we have to see if they have any risk enhancers in diabetes, that is target organ damage, which is proteinuria, retinopathy, above all proliferative retinopathy, which is associated with an increase of cardiovascular disease. The renal function, I'm sure most of them will have normal renal function, and the duration of diabetes. It's a reality that most studies performed with statin have not included, or the number of patients included with less than 40 years are fewer or are not a huge number. But I think we have to, in this group of patients, think about giving statins in those who have long duration of diabetes, or who have organ damage, or who have other major associated cardiovascular risk factors. The evidence from guidelines is less, because from studies is less, because randomized controlled trials are mainly performed in patients above 40 years. But I think we have to bear in mind these factors that are associated with an increased risk. These patients would benefit from statin, at least moderate intensity in statin, I would say.
Dr.
So
Uni,
thank
would
you
you
for
like to
that
add
question.
to that?
Thank you for that question. I'd like to state that if you're looking at a South Asian population, one of the scores that actually look at a South Asian population is the JBS3, or the Joint British Society's 3 score. So that actually includes some South Asian population. The rest of the ASCVD scores may not include the South Asian population. The other thing about the ASCVD scores, these scores are accurate. Cutoff of more than 7.5% suggests risk, but they are more accurate if the age is more than 40 years. So age less than 40 years still seems to be a clinical decision which you'll have to take after discussion with the patient. So I think if you have a 10-year ASCVD risk of 7.5% or higher in a person without pre-existing ASCVD or diabetes, then you will look at it as an increased risk. But wherever possible, if you're looking at a South Asian population, I encourage you to download the free JBS3, Joint British Society's 3 calculator, which is available online, and use that, because that includes the South Asian population. Some people have said that a Framingham CHD calculator is also equally good, but I think the JBS3 is good for South Asian population.
Thank you, Dr. Unni. I'll agree with that. Dr. Nuria had also spoken about the American guidelines suggesting the use of QRISK 2 in South Asians. Now that has been supplanted by QRISK 3, and you can go to JBS3 or to Cures3, and you can actually fill in your nationality also, Indian, Pakistani, Bangladeshi, other Asian, and that gives you a fairly good risk. We use this as a motivational tool in our clinics. Sometimes you find it difficult to motivate the patient to take statins or to take other treatment. Then if you give a quantitative value to the risk, that actually helps the patient adhere to therapy. Dr. Khalid, we have a greetings for you from Dr. Abdul Qadir Khan from Pakistan. What he asks is a 35-year-old male with dyslipidemia and triglycerides are high, 500 milligram percent. What treatment would you want to start if the patient is diabetic and if the male is non-diabetic?
First of all, I would like to know whether this particular patient is already on statin or not.
Assuming that he's treatment naive.
He's treatment naive. So definitely the first step after diet and lifestyle should be a statin. Once the statin has reached a tolerable or maximum allowed dose, and if still we feel that the triglycerides have not come down, then next step, of course, is to go in for a fenofibrate for this particular patient.
Right. Thank you. We have a question for Dr. Zhanay as well. In Kazakhstan, how often do you use statins and fenofibrate together? And how much of myopathy and myalgia do you see in your clinic?
Yeah, thank you very much for question, Professor Kalra. The situation is very interesting. You know that as we well know that diabetes is Asian disease. We're understanding that more than 40% of all diabetic patients living in Asia. We're understanding, and of course we know there's some problem that's in Asia. We have no diabetic insulin resistance. Mostly we have the insulin failure, insulin producing failure. In this situation, of course, we have a lot of the patients who already have a lot of complication because we have atherosclerosis, it's a general atherosclerosis. In this case, we should start our therapy as soon as possible. And of course, to check in cholesterol level and the all cholesterol profile, we're understanding that the patients have a problem. Usually, we're using just statins. But that's unfortunately in Kazakhstan, we have another problem. Our Asian, Central Asian persons, the patients, the people, nation, is a prefer to eat a lot of the meat, you know. We're eating a lot of the fatty meat. This is the problem that we have cholesterol level, the general level on 9, you know. That's in this situation, of course, we should to think, what we should to do. And any scheme will be very good to reduce this level till I think that's till 6 is a very good results, This is true. And last about the new, the way and new kids on the block, same like as ezetimibe, you know that in Kazakhstan we should wait. We're trying to wait at least. That's what kind of results will show in Europe and America. And of course the Asian, the same like Japan and China. But now we're using that maybe previously scheme of the treatment of the atherosclerosis in the Republic of Kazakhstan, like this.
Thank you. Dr. Nuria, a question for you from Dr. Sufad. A person is already on high dose statins because he had myocardial infarction. Now he develops ischemic stroke or he develops hemorrhagic stroke. How would we change therapy? And what are the risk factors for developing hemorrhagic stroke? Like, for example, apart from the statins, would you focus more on blood pressure control? What would you do? So how would this influence our treatment?
So if I have understood, it's a patient that has a stroke,
previous MI,
a previous MI, and now has a stroke, which is a second cardiovascular event.
Yes.
And is taking a maximal statin dose.
Yes.
You mean?
Yes.
So this case, it would be the treatment would be depends on the LDL level, but I'm sure he will be suitable for PCSK9 inhibitor. And also, of course, you can try to put before ezetimibe, but the percentage reduction in LDL you need won't reach a 50% reduction from the level you have on LDL. So you'll need a PCSK9 inhibitor.
Right. How common is fenofibrate use in Spain, and what are the indications?
Yeah, we do use fenofibrate in Spain, mostly in patients with diabetes because of the atherogenic lipid profile. And we do usually give the fenofibrate in patients who are really who are on statin treatment. It's not the first choice. Diabetic patient who is on statin treatment, and despite this, the patient has high triglycerides levels, most with low HDL, high triglyceride level you can consider above 200, and an HDL below 40. But mainly because the beneficial effect on cardiovascular disease of fenofibrate associated to statin has been observed in this subgroup of patients, those who have atherogenic dyslipidemia. But I would like to point out that for all patients and above type 2 diabetic patients with insulin resistance with this atherogenic lipid profile, to insist on the importance of the diet, the healthy diet and the physical exercise to reduce triglyceride levels. And also the diet recommendations with avoiding refined carbohydrates and alcohol intake that increases triglyceride levels.
Thank you. Dr. Kamini, how has the last hour been for you? Did you learn anything new? I learned lots of stuff. So, any more questions? Should we ask our panelists to give one final comment each before we close? Dr. Unnikrishnan, comments from you. In one sentence, what do we do about dyslipidemia in South Asia?
I think one important thing is diet, of course. And in diet, I think we must limit carbohydrate consumption, restrict trans fats, and maybe it's time for South Asians to remove the limits on saturated fat. That's something to consider from the diet point of view. For medicines, I think right now, it's not that statins are overprescribed, they are still being underprescribed. So I think optimization of statin dose is key in South Asia.
Thanks. Dr. Khalid, any comments, any best practices from the Middle East regarding dyslipidemia management?
Yeah, I would like to introduce terminology. Usually we do discuss, as far as Dr. Unni was just now explaining about diet, I would like to introduce this term called Mediterranean diet. And by Mediterranean, we are meaning it's a combination or similarity between a Mediterranean diet and an Asian diet. In fact, I was planning to present it, but due to the time constraint, I couldn't put that slide. It's a beautiful combination what we have in our daily food habits, like, in salads and stuff like that, or our lentils, which we call dal, are actually a Mediterranean or a Greek salad, which can be compared to that. So I would say, right, we start from diet and then, of course, we go to the different stuff. Thank you very much.
Thank you. Dr. Zhanay, any comments from your side? How can we improve diabetes care and lipid care in South Asia?
So actually, that's, in Kazakhstan now we have the special program, the program for prevention of diabetes and all complication of diabetes. Maybe this is global burden for diabetes for Kazakhstan, the diabetes global burden for Kazakhstan. Yeah, and one of them, we're starting the primary healthcare project to reduce the quantity of the people who unfortunately did have the very good food behavior. The food, that's the try to do not eat the very fatty food or something. Unfortunately, we're just starting, and we have no preliminary data. But when we will, of course, I will share with you, especially with your federation, because there is Asians, and we're working together. And we try, of course, to make some paper and to show the results. Yeah, but now we can say just directly about the results. But we're starting this program, and we're trying to changing the philosophy. Changing for the healthy lifestyle is more important, like medicine, like medical support, But so nobody knows. We will show the results later. This is our opinion, colleagues.
Thank you. That's
Well,
been great.
Yeah.
Dr. Nuria, I was just about to ask you. You're a leader in lipid research, so maybe final comments from you and then from Dr. Kamini.
Yeah, I would say that as all the speakers have talked before, healthy lifestyle diet implementation is crucial to prevent cardiovascular disease with the diet and physical exercise. That's the most important. And I would also give the message that since Lp(a) has been described to be indefinitely associated with the cardiovascular risk, and given that it has been described also that in South Asian people, these levels are really increased, that at least once in life, Lp(a) should be determined in people, which is recommended in the European guidelines, in order to, above all, in those with a premature cardiovascular disease history in the family, to better know the cardiovascular risk of the patient.
Thank you very much, Professor Alonso. So one problem we have in Sri Lanka is even though people are prescribed statins, they go through that lipid profile and they think that their cholesterol is normal. So most of the time they are having very poor compliance to statins. So I think that's one thing we need to address as physicians. So anyway, with the interest of time, I think we should conclude the session now. Thank you very much for the interesting discussion as well as the talks. Dear Professor Sanjay Kalra, thank you very much for coordinating. And I wish to thank again Professor Nuria Alonso, Dr. Unnikrishnan, Dr. Shaikh, Dr. Akanov for their wonderful talks. Thank you.
Thank you.
Thank you, and thank you for having me. Pleasure being here.
Thanks.